Hello. I don't think we need it, but still. Yeah. Thank you for making me part of this wonderful course, and you do a great job of whatever you do. So, childhood keratoconus prevalence, unfortunately, the data is not very widely available in the literature, but there are some studies, and recently one big data study from LV Prasad, which didn't specifically look at pediatric keratoconus, but it did a large data of the entire keratoconus population in their this thing, and I'll share a few images from that as well. So, there was this pretty large 2,972 patient data set from Lebanon, which evaluated children less than 14 years old, and they reported an incidence of 0.53, which is 1 in 200 cases over a period of 5 years, which represents 2.9% of the keratoconus of all ages. This study from Riyadh, which was actually significantly more, they reported almost 4%, 1 in 25 pediatric children having keratoconus, and average age at diagnosis in this subset was 15 years, and some cases were as young as 4 years. And of course, as we know, most of them have male preponderance. So this was a massive big data study from LV Prasad, and they found about 1% prevalence of keratoconus in the pediatric population, which is somewhere in between the other two data sets which we talked about. You can see this graph showing the decade-wise prevalence of keratoconus, and between 11 to 20 you have a significant percentage of that population. So another thing that happens in these children is they often have comorbidities and associations which are which may be genetic. So atopia, vernal keratoconjunctivitis, environmental factors such as persistent eye rubbing and eyelid laxity from other reasons. There is a higher prevalence of keratoconus in patients with Down syndrome. However, they have not really found a genetic correlation, but possibly it's because these children tend to rub their eyes, and that rubbing is what's causing the environmental insult, which we know it's like a two-hit hypothesis in keratoconus. There is a genetic component as well as an environmental component. Then other genetic conditions like Leber's congenital amaurosis and mitral valve prolapse, retinitis pigmentosa, etc. So when you talk about genetics of keratoconus, a lot of gene loci have been studied, but no a single gene has been identified. Multiple genes possibly play a role, and they have it's not just genetic, but it's a combination of genetics and environmental factors. So I think although we know that there is a genetic association, we still don't know exactly what is going on. If you take into account the subclinical forms of keratoconus, then your first degree relatives of patients with keratoconus have 15 to 67 times high prevalence of keratoconus compared to the general population. So there is definitely something going on there. And some families with keratoconus, 90% have shown autosomal dominant inheritance, but there have also been some which showed autosomal recessive inheritance. So one of the things which is different about keratoconus in kids is, one is how it presents, and second is how it progresses. So unlike adults, which usually we pick up at a milder grade 1, grade 2, grade 3, pediatric keratoconus, you must all have seen, often you will see at a more advanced stage. So sometimes you may have as many as 30% at stage 4 compared to 8% at stage 4 in adults at presentation. So when they come early, they come more advanced, and when they also tend to progress much faster. So 88% will progress to about 2 diopters of increase in Kmax within 12 months, within a year of presentation. So that is something definitely to be concerned about, and that is probably why our threshold for intervention in pediatric cases is much lower. Also, the ones with central ectasia tend to progress faster compared to the ones with peripheral ectasia, and that central ectasia is also much more common in this particular population. Patients with asymmetric disease have been shown to eventually develop keratoconus due to even in seemingly unaffected eyes in 35% of cases over a period of 8 years. So don't think that it's a unilateral ectasia. Eventually the other eye will develop some sort of an insult which will eventually lead to development of keratoconus in that eye. So this is just a representative case. One of my patients, 14-year, and you can see it's moderately advanced keratoconus in both eyes, and obviously he needed some sort of intervention for that, not just an observation. So one could observe maybe very mild cases, and older children you may want to just see, especially if they have a history of eye rubbing or associated vernal or atopic disease. You may want to treat that and see if the eye rubbing settles and the eye doesn't progress. But I think for most other cases our threshold for intervention is lower, because we do know that these children do progress faster. Other modalities, of course, contact lens is definitely possible in a large subset of keratoconus patients, but the challenge with contact lens is compliance, and many of them have associated allergic eye disease, which makes fitting of contact lenses a challenge. Cross-linking definitely has a very important role in pediatric population. We'll be discussing all of these. Intracorneal ring segments, I don't have any experience in kids, but there have been a lot of reports of use of ICRS in combination with cross-linking. And of course, final frontier is keratoplasty. Penetrating keratoplasty is what we were doing in the past. Nowadays, predominantly it's a DALC, unless you have a central scar or hydrops or something. So contact lenses, of course, all types of lenses can be used. Some children, like I said, compliance and safety is a challenge in these cases, and associated comorbidities like allergic eye disease. Sometimes you can be surprised how young kids also you are able to fit lenses very well. So it's definitely worth a try, but you need a lot of effort from the parents, and if that is not there, then it becomes difficult. Cross-linking, I think, is a very, very nice intervention which we have for pediatric population. Surprisingly, many children will actually cooperate for topical, and you don't really need to sedate or give them general anesthesia if you just talk them through it. So you can assess them in the clinic, and if they are reasonably cooperative, I have done it for as young as 11, 12 years, and they do work. But anything younger, it's probably a good idea to at least sedate them or give general anesthesia. And if you're giving general anesthesia, it may be reasonable to actually do sequential bilateral cross-linking rather than subject them to 2 general anesthesias. And of course, you have to follow all the precautions of bilateral surgery, so you have to use everything different. There are a lot of controversies in pediatric cross-linking, whether one should be doing a epi-on versus epi-off. Epi-on obviously is more comfortable for the child, and post-operative comfort, etc. will be better, but it will be less effective. So you want something which works better, but you also want something which has lesser potential of side effects and will make the child a little more comfortable post-op. But in general, I think most of us would prefer an epi-off, because we want that cross-linking effect to be there effectively. We know epi-on is not as effective. The protocols, ideally resident should be done for children because it is more effective, but there are 2 problems with that. One is it's longer, so you want to shorten the duration of the surgery for compliance and general anesthesia duration, etc. So I think a reasonable cutoff is to use either a 9:10 or a 10:9 combination, and that works reasonably well, and that's what we do in our pediatric cases. Whether to use do unilateral or bilateral, again, depends on what you're doing. If you're doing topical, of course unilateral is good, but if you're subjecting them to general anesthesia, I think it's reasonable to do a sequential bilateral. One can combine with other procedures like excimer and ICRS, but we have to be very wary about thinning these pediatric eyes, because we know that over time cross-linking effect goes on for many years, and you may end up with a very thin cornea eventually. So I don't really like to do any sort of a laser intervention in children, and ICRS I have not used, but there have been a lot of encouraging reports of that. So if any other panelists have experience with that, please do share. And cross-linking, one thing is there, that we know collagen turnover happens over every few years. So the effect of cross-linking tends to go away after a few years, and you may need to repeat cross-linking after few years, 3, 4, 5 years in many of these patients if you start seeing signs of progression. So we have to keep a close watch and repeat if necessary. So which protocol to use? In the pediatric population, like I said, we can use 10 milliwatt into 9 or 9 milliwatt into 10. These are the ones which have been studied. There have been no studies which have followed patients beyond 3 years. So we really don't know whether one is better than the other for the longevity of the cross-linking effect. Although we do know that they work almost equally well in the short term. So there has been this systematic review of cross-linking in children with keratoconus, and it shows that in spite of cross-linking, 10% of them will still progress. So you have to still watch them, and if you're getting progression, then you need to accordingly advise these kids and explain the prognosis and plan your further management. Standard cross-linking helps stabilize definitely for a period of 1 year, but after that you may start seeing a regression of the cross-linking effect. So a lot of studies have been done, but most of them don't have very long follow-up, and that's the main disadvantage of these pediatric cross-linking studies. So penetrating keratoplasty definitely is a good option for pediatric cases, but we know that pediatric population is high risk for rejection and failure, and therefore we want to do a lamellar procedure as much as possible to increase the graft survival and prevent any chances of endothelial rejection. Stromal rejection can still happen, but most times stromal rejection does respond very well to medical therapy. So just some of the issues related to pediatric, I'll just talk about DALC a little bit and then I'll close. How am I doing on time?
Yeah, you have.
Can't see the timer.
30 seconds.
Okay, so I'll quickly run through. So OCT I think is a good idea. So to understand what's happening at the depth of your cornea, and if you're seeing any distortions in the deeper layers, then you may want to consider a pre-desmetic DALC rather than go all the way to the Duas layer. You have the smaller globe size, lower scleral rigidity, and thinner corneas, more pliable. So you have to take all these in account when you're considering your surgical strategy. You want to refine central to the limbus rather than to the pupil. Technique, I usually prefer manual techniques of DALC because they are in my hands, they work lesser. A big bubble is a great technique, but in case you get a type 2 bubble, then you may end up having to convert to a penetrating keratoplasty. So I like to use this particular technique called the groove and peel technique. I won't go into the details of the technique right now. So, but basically, essentially, we are using stretch forces to kind of separate and open up that pre-Duas layer space. I do tend to oversize DALCs, although traditionally they say that you don't need to oversize in ectasia. There was a study comparing the refractive outcome of femtosecond versus manual refination in pediatric DALC, and they found that manual ended up with more spherical equivalent of minus compared to femto. So it may be reasonable to consider femto if the child can afford, and you can logistically do all of that. I have done a few DALCs in keratoglobus and brittle cornea syndromes, and what I found in these cases is when you open up the deep stromal layers and reach the pre-Duas layer space, actually the entire thing peels off like a LASIK flap. There are really no attachments. So it's easy to actually dissect, but it's sometimes difficult to do your peripheral anchoring of the graft to the host because even the sclera may be thinned out in some of these cases. So this was that study I was telling you. If you have access to intraoperative OCT, it will make your life a lot easier, but 99% of us don't have access to this. So studies have shown that we can have challenges, rejection can happen, but most of these can be overcome and you can have reasonably good outcomes. So this just show you some of our pictures. This was a patient of keratoglobus, 5 years post DALC for keratoconus, and this was a review from AIOS, Dr. Namrata Sharma of their pediatric DALCs. This was another from Jatin Asher, etc. from LVP. So they had complications. This was our little series which we had done some years ago, and most of these were keratoconus eyes. And you can see predominantly we have clear grafts, except one patient which was a viral keratitis which had a scarring in the graft. So these children often have good outcomes even though they may have complications like rejection, which can be treated with medical therapy. So this was just one case I'll show you and then I'll close. The patient was doing a DALC, had a perforation. I had punctured the bubble and then the punctured then 2 hours later. You can see central perforation. So it's leaking out. So we sealed that with fibrin glue, then dissected all around, and then left a little patch of stroma in the center, and then put the graft on top, and later we gently teased out that little graft, and it did well on table. But next day, this is how the cornea was. There was a double anterior chamber, and that area had allowed fluid to go, and you can see the DM perforation there. And then we put C3F8 gas because it was central. It opposed well. You can see on the OCT the gap there, and by 3 months you can see that clear area which shows the site of the perf. Patient did well, but then eventually had a rejection, stromal rejection, treated with topical steroids, and then cleared up, resolved rejection. Very clear graft, but high astigmatism. By this time the child was about 15 years, so she was not able to study well, and not able to wear lenses. So we did a topography guided laser in this particular case because it was post-DALC, and regularized the cornea, and then she maintained very good vision, and she's following up with me now. Now she has a child also. So to conclude, pediatric keratoconus is challenging entity due to more advanced pathology at presentation, rapid progression, need for GA in surgical intervention, poor compliance for therapy, and presence of comorbidities. Cross-linking in pediatric eyes has a lower threshold for selection, may consider bilateral sequential treatment for GA, and may need to be repeated. Pediatric DALC is safe and effective alternative to penetrating keratoplasty in pediatric eyes, and various techniques can be tried depending on the surgeon comfort, depth of pathology, and availability of corneal tissue. Thank you.
Thank you so much, Dr. Rishi.